experts who use technology to fuel innovations in brain health. This is Brain Tech Project Podcast. Thank you for tuning in to the Brain Tech Project. I'm your host, Dr. Cristi Salinas, and today we'll be speaking with a world expert in neuropsychology and teleassessment, Dr. Munro Cullum.
Sure. I'm a professor of psychiatry, neurology, and neurological surgery. I'm a board-certified clinical neuropsychologist, so I'm involved with the evaluation of patients with a host of known or suspected cognitive disorders. I work mostly with adults in our outpatient clinic here at UT Southwestern Medical Center. I've been doing this work here at UT Southwestern for over 25 years now, and but longer in the field before that. I have active research programs in concussion and aging and dementia and telehealth applications of neuropsychology. And I supervise students and trainees at all different levels. And I'm a chief of a division of psychology as well. So I oversee all of the psychologists in the medical school at the University of Texas Southwestern Medical Center. And I see patients as well for neuropsychological evaluation.
Great. Yes, so you're definitely juggling several different service lines there. And thank you today for taking the time out and sharing your expertise with us. I know that one of the areas that we have a mutual passion for is sports concussion. And so I'd like you to share a little bit about your work in the arena and also kind of weave in for us about technology, how you think that plays a role, especially with athletes.
Sure. So I've had a long-standing interest in traumatic brain injury of all severities, but concussion specifically, which is a mild traumatic brain injury. I've been working with I've had the good fortune to be working with the Dallas Cowboys and the Dallas Stars organizations for over 20 years now as their team neuropsychologist. And that's really been really enjoyable work. It's a very applied aspect of the clinical work we do, and does involve the aspects of technology as well, along a couple of lines. First of all, the NFL and the NHL, actually the NHL was the first one to start kind of a league-wide baseline cognitive assessment or cognitive screening for all the players. The NFL adapted a very similar program as well, such that as you're familiar with, all of the NFL and NHL players get a baseline cognitive test where they sit at a computer, take a computerized test that tests things like attention concentration, a little bit of memory, thinking speed, and things like that. And then if they have a concussion during the season, we retest them with that same battery of tests to look for change. And in addition, we conduct a more traditional brief neuropsychological evaluation of them also to really thoroughly assess how they're doing, to help the trainers and team physicians determine whether they've recovered from the concussion, because as you know, most people recover within days to weeks following a concussion, but we want to make sure that certainly our athletes are back to normal before we return them to the field of play.
And so in the good old days of even neuropsychology, what were the discussions about the use of technology, and how could that be analogous to our situation currently, where now we find ourselves having to use technology, obviously during the COVID crisis? And how do you think that, what were the discussions then, and how may they be similar or different to the conversations today?
Sure, that's an interesting topic. So early on, there was a lot of discussion about how to test really, really large groups of athletes. I mean, you've got a team with over 50 individuals. How are you going to, conduct a neuropsychological evaluation on an individual basis on 50 people every year if you don't have a cadre of, research assistants, technicians, graduate students, et cetera? Because there just aren't that many neuropsychologists in any one city that could conduct so many evaluations. So that's where the idea of this computerized testing really evolved, and the NFL and the NHL programs reviewed all of the computer systems that were out at the time. Again, this is going back more than 20 years now. They had the different test companies that at the time were publishing and making available computerized measures. They had them all come to present to a panel of NFL and NHL experts, and then decisions were made about which one seemed to fit the bill the best at the time, keeping in mind the significant constraints and limitations that computerized testing have. It's far from ideal.
Right.
Most of us do not believe it's as good as a traditional face-to-face neuropsychological evaluation. When we factor analyze or do statistics on large numbers of these tests that are done, the computerized tests tend to have fewer factors in them. That is, they're mainly assessing aspects of attention concentration, a little bit of memory, and then processing speed or rapid thinking, basically. And they're not able to assess some of the more detailed nuances of memory or executive function or some of these higher order cognitive abilities that neuropsychologists will typically assess in a neuropsychological evaluation. So, but with that in mind, there was certainly an imperative for a brief assessment to be done. It was felt it had to be computerized in order to do large groups. So people started trying out the computerized tests back in the day, finding out that large group administrations were probably not a good idea. You would get some of the players would be goofing off in the back, and some of them would be on their phones, looking up information and or just carrying on. And this was especially true at the high school and collegiate levels. I can only imagine if, putting my son when he was a teenager through these tests and saying, here, son, pay attention to this and do your best. If he's in a group of, 30 or 50 athletes in a room, it's going to result in huge numbers of invalid tests, basically, with, for different reasons, people not paying attention, not really trying. In the old days, the term sandbagging was also used, where some of the athletes would kind of figure out that, let's see, if this doctor is going to test me after I'm injured, my scores are going to be low, maybe I'll go ahead and give them some low scores now so they won't be able to tell that I'm impaired later on, and therefore I'll get to stay in the game. Well, fortunately, neuropsychologists are really good at detecting poor effort, and our tests help us with that. So I think that was an issue early on, but certainly in the professional leagues now, it's really not much of an issue. They know that if they don't give it a good shot, and if they turn in kind of an unusual looking performance, we're going to make them retake it, and they don't want to do that. So the good news is that really all professional sports now have concussion programs that include baseline and then follow-up post-concussion testing, all the way from NASCAR to Major League Lacrosse and pretty much everything in between.
Correct. Yeah. So I think that this is a wonderful story, not only for the public to know, to be reassured that, we work as teams and we're able to implement this across, a huge industry or, populations like sports, but also for the field to know that pre-COVID, right, there were ways to just ramp up and have initiatives to develop the tools that were needed at the time. Now, how long, because again, I'm not as familiar of the exact history, do you think it took for the adoption of computerized testing from the conception of the idea to actually implementing at these pro levels? Was that a couple years process, or how long?
Well, it took over a year just for the leagues and the neuropsychology leaders in the field to really decide on which test package to use. And then once they were decided upon, most of us have been using the similar programs now for a long time, and there haven't been a lot of changes made in those tests. So I do think the time is probably right for some out-of-the-box thinking, which I think this COVID-19 situation also presses us on as well, thinking about how can we do these remote assessments, not just sitting somebody down at a computer 100 miles away and telling them take the test and I'll look at your results later, but rather how can I interact with you as a patient right now in your particular environment? And that's where the teleneuropsychology or video conference-based neuropsychological testing kind of arose. back in the early 2000s, although there were precursors of work along these lines done back in the early to mid 90s is actually when it started.
Yeah, if you could share with everybody, I totally agree. I believe again in thinking about our patients in the real world where they are. And I do lifespan work, but certainly focus more on pediatrics these days. And technology is just where they're living all the time. They're there, they're interacting, they're learning how to use the technology from infancy, it seems. And so I think it's an opportunity to understand some cognitive functions that we're not able to tap with our traditional measures that we've been doing. Can you tell a little bit of why, obviously you've been doing this work for quite some time, but why you think now is the time to utilize technology and what is the cost of not doing it?
Those are really, really good questions. I think now is the time, obviously, because we're sort of forced into it. I mean, as practitioners, and it's not just the field of neuropsychology, it's really all of medicine, all of psychology. Uh, do we continue to provide these important services to our patients, or do we tell everybody you have to wait until you can come into my clinic, perhaps several months down the road? There is a lot that can be done. There are a lot of caveats to the practice as well, but there's a lot that can be done remotely. Years ago, some nice telephone screening cognitive tests were developed. They work pretty well. They're reliable. They've been used in really large scale epidemiologic studies of aging in a variety of contexts and different research projects. But I think, with this new stay at home, or if you're in the clinic, you're the only one there, perhaps. This new mandate that we have, it's really pushing us to think about how can we keep getting these important services out to patients. And there's some pushback. Not everyone agrees that this is a way to go. And there are obviously limitations, and there are risks involved to this sort of a telepractice, if you will. But I think we have to embrace it. I think we need to take advantage of the moment to develop some at least alternative or optional procedures that we might consider even when this crisis is over. Now, I will never advocate for the use of a teleconference-based assessment in place of a real world in the clinic evaluation. I wouldn't do that. But in certain applications, it may be adequate. For example, an initial consultation, a visit for a clinical interview, and maybe a brief examination to help triage patients. Oh, you probably need to come in to my clinic, 2 weeks from now, and we'll do like a 2-hour assessment versus another patient that may need, I think we'll chat over the video conference or over the phone. I'll do an initial screening, if you will, mostly an interview, get an assessment of your symptoms and whatnot. I could even send you online questionnaires to fill out and get information before we even talk virtually. And then decide, in your situation, there's really very limited things we can do in this environment of virtual space, but come into the clinic and we'll set you up for probably a half-day evaluation a month from now, or whatever that will be. Of course, this pushes people outside of their comfort zones, wondering what tests can be used, which of our standard neuropsychological tests can be used in this environment, because we're all used to giving a whole panoply of tests of attention, concentration, language, visual spatial abilities, executive function, memory, different types of memory, visual, verbal, delayed recall, recognition testing, all sorts of tests. We've got hundreds of neuropsychological tests available to us. So when patients come in for evaluation, we're well armed, well equipped to administer the latest measures in standard fashion. But now with this distance assessment approach, it changes the practice a bit, and it does kind of narrow the scope of the tools available to us. And I think it's going to push people to lean a little bit more back on their traditional clinical skills and judgment as well, maybe some more qualitative features of performance assessment.
So I think what you've really summarized is that we have a lot of skills and value that we bring. And it's not only within the testing, but within our skills as clinical psychologists as well. And certainly we both embrace technology. We want to keep the validity and standards of our testing and, high fidelity of our field. However, right now we're in this forcing function where we're also patients are waiting. And one of the things I was thinking about was the costs to the patients. I was thinking about what are the typical waiting times that you're familiar with, for example, across the country with memory disorders clinics. Could you address that, just what you think are the typical waiting times and how technology might help reduce that, especially for spouses or children who see their parents struggling?
Well, so that is an excellent opportunity for technology, I think, to really help all of us out potentially. So wait lists for neuropsychological services are endemic, certainly across the United States, if not across the world. Um, from people I know in memory disorder clinics all over the country and Alzheimer's disease centers, the waits for clinical evaluations are up to 2 to 3 months in a lot of settings. We went through a massive clinical expansion over the last 2 years here at UT Southwestern to add more neuropsychologists so that we could get our wait times down. And we actually got them down to about a 2 week window, but
Wow.
then we quickly filled those up, and now we're about to another month to 2 months out. So it is an ongoing challenge. The good news for our trainees is that we need more neuropsychologists, which is great news. So that's where I think this technology may be able to be of some real benefit in terms of helping us with an initial triage visit, initial screening, maybe doing a bit of a clinical interview to determine really what testing needs to be done. So when someone presents to any of our clinics, obviously we're figuring that out on the fly. If somebody comes in with a mild memory problem and you start testing them and they can't remember your name 2 minutes later, they don't remember the names of their kids, they're disoriented, it's way beyond a mild memory problem.
Mm-hmm.
So then my planned evaluation for that morning, which I might have set aside 2 or 3 hours, suddenly now we're condensing the assessment time down to about an hour, and sometimes it's even less, depending on severity of impairment. So I think these sort of the tele visits may really be very helpful in helping us to maybe streamline the process a bit, figure out who actually needs to come in for what type of assessment, and then when we can get them in. Now that'll cause changes in practices too, in terms of the tele-based work is not without its toll on your time also, in terms of insurance authorization. You still have to get all those procedures done. You've got to get the technology set up with the patient, often with a caregiver or spouse or family member to assist getting it set up anyway. So it can take a fair amount of legwork just to get these things set up. But I think there can be some time savings. Again, for a thorough evaluation, I'll always want to see patients in the clinic, but if it's for a brief cognitive screening for someone, let's say they're in their 70s, they're worried about their memory, their primary care doc says, yeah, there might be a memory problem here, but we're really not sure. And you chat with them and you find out that the thing that they're forgetting is once in a while they forget a password on their computer. And that's the extent of their memory complaint. Well, that's a pretty normal thing for even people in their 30s. So that person could probably be screened adequately via remote assessment, and that may be all that's needed at that point.
Mm-hmm. And can you address also, how about a middle-aged person that might be a differential with a mood disorder, and how could, again, tele be useful in terms of what you're saying, in terms of an interview and a screening that somebody could address with tele?
I think those individuals are also prime candidates for remote screening for mood disorders in terms of severity of mood disorders. Now, obviously, a lot of our assessments in those cases are based on responses to clinical questions and or clinical questionnaires that we might be administering, or the information we might be collecting from them. So if we can have someone complete one of the standardized questionnaires about mood, anxiety, depression, whatever, remotely, have that get to the clinician before the interview, I think that compresses the time that's needed also. But you could, screen for, certainly severity of an obvious mood disorder remotely pretty efficiently. And actually, you might be able to, obviate the need for someone to come in for a formal, full workup at that time based on your clinical interview and some screening information.
Mhm. Definitely. And what's the cost of not doing that again with someone with a mood disorder or that 70-something-year-old patient that you just addressed? I hear definitely that you're saying we can optimize our efficiency. What's the cost of not doing that for these types of populations that you just described?
I think there are costs at several levels. One is to the clinician and their backlog of cases, but more importantly, it's sometimes to the patients and the families of the patients. So, if someone drives for 4 hours to bring a patient to see me with, again, a mild memory complaint, and they're severely demented, and I'm only going to see them for an hour anyway, that's a lot of use of a lot of people's time. That's taking the patient out of their home, out of their environment. The caregiver may have to take time off work to bring them in. So they may spend more time commuting to see me than they would actually spend with me in the clinic. And again, if we can rule out a significant mood disorder or cognitive disorder via a clinical interview and maybe some screening mental status examination, I think that can save everyone time and also save on costs to the healthcare system as well. If shorter evaluations might suffice for some individuals in some settings, that's going to save people a lot of money all around.
Mhm. Yeah, and definitely, obviously, the stress involved, right, with waiting 3 months for care. So, as we know, the longer they're waiting, the less education and connection they're having with a professional, right? They might actually think they have Alzheimer's disease, and then they find out that they don't. And imagine again the less burden on caregiver burden and just mood problems that will kind of exacerbate. So, I think we have an opportunity in being efficient. We actually are maybe treating patients as well. Um, Another area that I want to work on talking about with you is a traumatic brain injury and also neuro rehab, if you work in that area, and how you think, again, technology, teleassessment, but even technology, maybe in other applications could be useful in brain injury. And it could be outside of concussion as well.
Yeah, so there are certainly a number of applications for traumatic brain injury. Just to start with concussion, I think remote screening and assessment of concussion is something that we haven't seen a lot of data on yet, but I think is in the near offing. We actually have as with other major medical centers and practices, we have a little robot actually that's got a video screen for a face, and something like that could be at the sideline of certain games if you want an athletic trainer to have a neurologist or neuropsychologist or other physician take a quick look at a patient, maybe do a quick exam. That sort of on field or right after game performance might be doable, as well as some sort of in-home assessment as well. For patients with more severe injuries, obviously it depends on their level of functional impairment, but this kind of gets into the rehabilitation world as well. Getting a sense of the patient's home environment actually can be really, really helpful, as you well know, for kind of how do we interpret our neuropsychological test results also and take those into the patient's home. Well, now we could actually get a view of the patient's home via telemedicine, video conference technology, and also get an assessment of like what do they actually do during the day? What is their environment like? If you've got a patient who's got some balance issues and you look around the room and they've got throw rugs everywhere and it's cluttered and there's chairs everywhere. It's like there may be some environmental manipulations we want to advise that would improve their health and functioning in a daily basis that we may never hear about or see anything about when we see them in the clinic. Touching base, doing some brief assessments during the course of recovery from traumatic brain injury may also be useful in terms of symptom questionnaires, clinical interviews, and some brief screening along the way. A lot of patients with more severe brain injuries are not necessarily amenable or need a detailed multi-hour neuropsychological evaluation, but in order to track progression as they get closer to consideration for return to work or school, if that's going to be the outcome, screening along the way consecutively over time may be really useful. And I think some of those brief screens can certainly be done in a remote technology sort of environment. Although, before returning anybody to work, I started going down that direction a little bit. Obviously, for return to work decisions for probably everyone, the telemedicine briefer assessment is probably not going to be anywhere near adequate. You're only going to get a little bit done within the context of a televisit. And we could talk about the details, the more pragmatic aspects of that and reasons why a little bit later. But
Yeah.
I think the
Yeah, I think where you were going was just the opportunity to see people in their real world. And I think a conversation that we have is ecologically oriented neuropsychology, right? Or how do our tests translate to the real world? Now we might give life-saving recommendations, that literally reduces a fall because we see how their stairs are set up and, give a very practical suggestion. So in with that in mind, and you were also talking about following repeat assessments. What are some particular populations or scenarios where you can think of where brief assessments might have us more often in that patient's life? What scenarios or patients might benefit?
Well, I think patients undergoing treatment with certain medications that may affect cognitive function, or where there are questions about variability in cognition throughout the day. Those patients we may want to monitor a little bit more closely. Anyone recovering from a condition such as a stroke, there's been some really nice stroke rehabilitation work out of Australia that's been done, looking at patients post-stroke and doing brief cognitive screening to track progress and actually conduct cognitive rehabilitation efforts. So to bring these services kind of live, as opposed to sending your patient to a website and saying, practice these things, you may want to supplement that with, let's just check in every couple weeks and I'll do a brief exam or a mental status exam with the patient and actually see how they're doing. And, I think that we'll get to this probably later, but the future, I think, is going to involve more interactive cognitive assessments and interactive rehabilitation efforts where, patients in their homes or their remote environment can be engaging in tasks or taking tests while the examiner can actually see what the results look like in real time. And we're not there yet, but I think that's going to be in the near future as technology makes an even greater jump into the lives of all of us, actually.
Mhm. Definitely. So I think to summarize and to continue the conversation is that our role might be expanded through telemedicine, and we might not just be involved with assessment, but actually treatment, ongoing treatment. So you brought up stroke. What are some other areas that you think are ripe and haven't been utilized, and that you think would be, if there was a early career person or someone out there in a department struggling, like what should we be focused on, Dr. Cullum?
Well, there's a lot of work going on with the whole, behavioral monitoring remotely using sensors and all sorts of, in-home detection. Gary Kay's group up at Oregon Health Sciences University has I've done a lot. Maureen Schmitter-Edgecombe's work at Washington State University also, looking at in-home monitoring methods of patients, using cell phone use for those who use cell phones to monitor their behavior, monitoring behavior of patients online as they're using their computers. For example, being able to detect when someone with mild cognitive impairment may be slipping into the early stages of dementia based on their use and errors made during their use of their computer during a typical day, or their cell phone use. Obviously, if patients are not feeling as well, if they may be ill, use of technology may decrease. So there might be some ways of us looking at signs and monitoring our patients in home as well. There's some Apple Watch and similar products that can monitor if someone hasn't moved for a while, X amount of time, or if they have wandered beyond a certain perimeter set. If somebody's got dementia and the family wants to know if they're wandering, they can be alerted if somebody leaves a certain perimeter. We don't want to get to the point of ankle bracelets here necessarily, but obviously if it's to ensure someone's safety, there are certain technological things that we can use. Now, this is largely in the research stage right now, and some would be difficult to deploy in some homes and settings. But I think as the technology advances, I think we're going to see a lot more use of sensors and these electronic means of behavioral monitoring as well, and looking for signs of cognitive change, cognitive decline, behavioral changes. I think that'll involve obviously advanced machine learning and algorithms to detect and predict abnormal change or changes outside. The individual has been functioning in this range for X number of months, and now things are different. Why are they different? Maybe that triggers either a phone call or a video chat with a relative, which might then trigger a time to come in and see your doctor, or check in for an appointment, or maybe see the neuropsychologist for an update because behavior seems to have changed. I think there's a lot of opportunities and potential for where this is going, as well as the whole area of computerized testing. I think there's a lot more that we can do, and we can take this further than where we are now.
Yeah, I think what you've been mentioning is basically more integrated, coordinated care between the patient, their family, and the providers, and some kind of interoperable system that can allow that. And the more data points we have, the more refined deep learning that we could do using this mathematical kind of, again, machine learning algorithms to determine some data even prior to our battery, or to even help compare that to the batteries that we have using real-time, real-world information from them. So I'm very passionate about that. What do you think are the barriers to doing that, and even to novel assessment methods to share with our listeners?
Certainly, there are many barriers at multiple levels. There are the practical challenges of how do you instrument people, how do you obtain these data from individuals, and then who is going to be collecting the data. If you're talking about monitoring over time, you might be talking obviously about massive quantities of data. So we're really talking big data here. Who's going to manage it? Who's going to analyze it? Most of us in a practice environment are not going to have the time or the resources to be looking at years worth of data from patients, especially as a clinician. How do you bill for some of these activities then as well? So there are going to be a lot of challenges. And then there's the issue of validating these procedures and techniques. So we have a lot of great gold standard tests. Right now, the neuropsychological tests that we have are the most sensitive means of assessing human cognition, human brain function. There's no scan, no matter how fancy it gets, that's going to tell you how somebody's memory is, or how they're functioning in real life, or how much they can remember, or what their decision-making capacity is. So these are very behaviorally based tools that we have, and they're the gold standards. But in order to provide for a detailed assessment, we also have to have an understanding of what's normal in all these different measures and metrics that we might be obtaining. So then you get into the need for these large normative databases also. Like all of our standard neuropsychological tests have some really good norms for a lot of populations, not all, but at least they're available as interpretive guidelines. And as we get into new technologies, we're going to need those large normative databases too. We can't just obtain data from patients with certain disorders, but we have to know what's normal and what the normal range is as well. So there are a lot of costs involved to not only in terms of test development, but test standardization of the algorithms and the analyses that are done as well. So this is no easy feat. We're talking about at least a decade of work here to really I think advance this aspect of the field of kind of neurocognitive assessment.
Mm-hmm. Definitely. And so let's move that also into another area that I think is challenging with thinking about technology, which is in the courtroom. And that's testifying, utilizing our neuropsychological assessments to make opinions that would be rendered in court. And can you share with people your experience and whether you've done that with tele or technology, especially, I know that some people have found themselves having to do that recently.
Yeah, so I've been involved in mostly traumatic brain injury, civil litigation cases, for over 30 years now. Probably only do half a dozen, maybe 10 cases a year. It's not the biggest part of my practice, but I've certainly done it. I've done depositions, court testimonies, and whatnot. Worked a lot with attorneys on these cases, advising them as well. So the tele applications, I think, are going to be much more limited in the forensic arena for a variety of reasons. Test security is one. Got to make sure that we're not sharing our test material and stimuli publicly. I always cringe when I see one of our tests shown on a TV show, which does happen on occasion, or you'll see some test stimuli posted online, somebody taking a test, and I just cringe. That's a problem, a threat to test security and violating some of the agreements we have with our test publishers, who are so vital in updating and developing these norms we were talking about earlier too. So I think the risks involved in a medical legal context when you get into the forensic arena are greatly enhanced. I could make my patient at the remote end promise to not record anything about what we're doing, but if they're holding their cell phone down there and I can't see what they're doing, that might get a recording of whatever it is we're talking about or doing, or what tasks or aspects of the case. Obviously, one of the big threats to is a loss of confidentiality in these sort of environments. If someone were to record part of it and that gets leaked or posted somewhere, that could be a massive breach of very, very personal security, not just test security, but personal health information too, which could be a whole nother issue as well. So I think there are a lot of limitations. Now, that said, I certainly would not do a medical legal neuropsychological evaluation via remote telemedicine. I just wouldn't do it. I've got to see the patient. I need to watch them in their nuances of behavior. And I want a very tightly controlled environment where there aren't the major risks of interference, interruptions of transmission, interruptions of dogs and pets and kids and doorbells and cell phones ringing and all these other things that can intervene and mess up an evaluation. So the only evaluations that I really recommend doing via telehealth at this point in time are really brief ones, quite honestly. The research that we've been doing since about 2006, we've only used brief batteries of tests that last about 45 minutes, quite honestly. And part of that is because we're focused on the assessment of aging and dementia. So we wanted a brief battery of common tools anyway used in that arena. But in this day and age with people testing people in their homes, there's so many more risks to the assessment procedure, that I don't think you want to do a really detailed or lengthy evaluation in that context. So I actually would avoid that. I could see maybe doing a clinical interview remotely, as long as it were carefully as controlled as possible in terms of safeguards of security and lack of recording and all these sort of things. Maybe do a mental status examination, but I don't think I would take it further than that in the medical legal environment. Although there are differing opinions in the field, on this very topic. I think it's something we're going to be grappling with increasingly over the next few months, especially maybe over the next couple of years, to deal with that.
Yeah, definitely. I'd like to know in Texas, even before telemedicine, just the use of technology. In some states, basically, it's become very common for neuropsychologists to be asked to be videotaped during assessments. And I'd like to know your experience, either personally or with others in the state of Texas, doing neuropsychological assessment with videotape, obviously assuring that another professional gets the data on the other side, so we know that there's no ethical test security issue. But what are your thoughts about, in general, videotaping during forensic neuropsychological assessment, and either your personal experience or others in the state of Texas or around the country?
I've certainly been asked and at times ordered to allow videotaping. In general, I'm opposed to it during the testing. So I've often allowed my interview with the patient to be videotaped. I really don't have a problem with that. But in general, I've not allowed attorneys to videotape the actual evaluation for several reasons. One is potential security issues, although you can take steps to ensure that that's only going to be viewed by another properly trained individual, and so on and so forth. But we actually don't know what the effects on the examinee, the person taking the tests, are if there's a video camera sitting behind the person testing them. Is that making them anxious? Are they thinking more about that camera behind the examiner than what the examiner is asking them to do? So there's a chance, I think there's a real risk of getting unusually low scores on some tests where they might have been distracted by the camera, or they're nervous, their anxiety is up. Well, if they're more anxious, maybe they don't test as well. If they're distracted by it, the red flashing light on the camera, or whatever it might be, the whirring noise of the videotape, if it's making a noise. Okay, I'm dating myself there in terms of tapes, but the idea is that we don't let other people sit in the room with us during these evaluations, and I don't feel we ought to have cameras in there either. Our tests have not been normed under those conditions. And in some patients, it may not make a difference, quite honestly, especially if it's a surreptitiously placed camera, although obviously consent would need to be obtained and they would need to be explained that the camera is there. But if it's not bothering them, if they're not aware of it, maybe that could be a valid way of assessing. But our tests were not administered or normed under those circumstances. So it could have an unknown effect on the actual test results that we get. So I tend to not allow that. And if a attorney says, "Oh, we're going to require videotaping of the testing," for myself in my own practice, I won't take the case.
Thank you. And the other area you were discussing was actually the briefer assessments that you've done with Alzheimer's and aging, and even in rural populations. Just so our listeners can, and we will share resources with them on our page after the podcast as well. What are some tests? So, 2 or 3 ideas that a clinician can take to think these would be the highest impact, for doing tele-assessment?
Well, there's some really nice reviews. There was a really good meta-analysis and literature review published a couple of years ago by Brearley and colleagues. We've done a variety of research studies in this area. We published some initial practice recommendations back in 2012, actually, when we were starting some of this work that some of the neuropsychological organizations are now taking and certainly developing in a much more detailed fashion. But the good thing about a lot of neuropsychological tests is that they are verbally mediated. We're asking questions, patients are providing answers. So a lot of them are quite well suited for a video teleconference environment. The tests we've studied most to date are things like, and have been published in the literature in a number of studies, the mini mental state exam, the MoCA, the Montreal Cognitive Screening Assessment, and then memory testing. Some of the list learning tests have been used, the Hopkins Verbal Learning Test, the CVLT, Ray Auditory Verbal Learning Test, some story memory tests as well. Some of our language measures, like the verbal fluency measures, have been done time and time again and worked really, really well in this environment. Auditory attention tests like digit span, forward and backward, their reliabilities seem to be a little bit lower in some studies, but still seem to be reasonable. And then there's some tests that we can also administer the visual stimuli, although it has to be done very, very carefully. We've used some of the Boston naming items in a brief format. Although that was in a controlled research environment. We published this in the Journal of the International Neuropsychological Society in 2014. We actually showed the visual stimuli on the screen, but we made sure that there was a precise distance between the screen and the examiner, the screen and the person taking the test, and then the size of the visual stimuli that were shown. And so there's a lot of caveats that we have to take into account. There is a research literature supporting the feasibility, reliability, validity, and also consumer acceptability of teleneuropsychological administered tests. But most of those studies have been done in pretty tightly controlled scientific research environments, not in people's homes. So as much as I'm pleased with the supportive nature of the literature that's been done, and most tests that we've tried and published on seem to work pretty well. You get pretty similar results. In fact, in the Brearley meta-analysis, they found that the difference between the video teleconference administration versus traditional face-to-face was less than about 1/10 of a standard deviation difference in the test results. And that's including studies that have looked up, a total conglomerate of about 500 cases across a number of studies.
Wow.
So we get similar results on the tests that have been studied to date.
Right.
So, the concern is if I just grab my favorite test off the shelf and decide to start doing it in this environment, especially if I'm showing visual stimuli, what is that doing to my ability to utilize the test norms that have been developed? If I show you a picture on screen, well, what if I'm really close to the camera and I'm showing you a giant picture? And what if you've got a little tiny screen at home versus I happen to be sitting in my living room watching you on my giant screen, and now you're going to have me copy this figure that now, it looks like it's 3 feet wide. So, obviously there's a lot more standardization that we have to impose upon that remote test environment than people might be thinking of. So I think that's one of the take-home messages today too, is
Definitely.
and also making sure that people practice. Don't start just jumping in tomorrow doing this with patients. Practice with colleagues, with friends, try things out, see what's going to work. And then go to the literature, be an informed consumer, and see what's out there. There has been an expansion of teleneuropsychological studies since this all started in the early 90s, but there's still only a handful of studies that have been done. When we did the work between 2006 and 2018, actually, my group actually thought this was going to explode and this was just the tip of the iceberg. And we didn't see a lot more studies. I've done an updated kind of a cursory PubMed search on a number of studies using the term teleneuropsychology, and they're inching up, and I suspect we're going to see a big jump this year.
Definitely. Yeah, I think that what you're saying is basically, to summarize, is the standardization, not only across device, across assessment tools. I'm almost thinking it as the common data elements. Many times there's cores, the CDEs that have been developed for certain conditions, like, for example, epilepsy. and we're still thinking about uniform data labeling, and things like that. We might need to start considering or think about what would be those core data elements and in which, system or device, and could we, our arm wrestle basically to decide what would be the best standard so that we could develop right together, propel the field forward. I think that's part of it. So there's definitely many challenges. We don't want to advocate, go home tomorrow or right now after this and say, go ahead and do a full assessment. But I think strategically to think it's not maybe impossible, but there are definitely strategic things we could think about as a field and put together. Um, so some other areas that I wanted to talk about was also, I know you're very involved with training and you've been doing teleassessment again in office. So when we're discussing teleassessment, it's in the office within a large academic medicine medical center. And what have been the advantages and benefits also to you as a supervisor, to your supervisees? And then again, thinking about access, how did that potentially expand your services at your clinic, at your center?
So most of my work in teleneuropsychology has been in the research environment. We are just starting to conduct some neuropsychological brief screenings via the video conference technology right now, quite honestly. My group, the Neuropsychology Lab, led by Dr. Laura Lakritz here at UT Southwestern Medical Center, has started doing some at least preliminary interviews via telehealth and setting up some brief evaluations. So we're really just getting into that. But obviously, it's going to be very important to include our students, our doctoral students, our postdoctoral fellows in this type of work so that they can be familiar with it as it does take off and become a more common aspect of practice down the road. So I think including trainees is essential. The trainees I've had involved have mostly been in my research lab. And fortunately, they've even been the leading authors on several of our publications, of which I'm really proud to see. But obviously, the kind of the younger generations, I think, take to technology more quickly than some of us who are a little further along in our careers, shall we say. But I think it's something that really ought to be included in all training programs at this day and age.
Mm-hmm. Yeah, and I think it's an opportunity to potentially even have virtual lab environments. As I've transitioned away from academic center, I'm not working with one lab, so I still am involved with publications and research, but the labs are in different parts of the world, and we meet virtually. We get some research done, and potentially, some thoughts are how we can have more global reach in terms of, we've been working on a teleneuropsychology initiative. I think the rest of the world is grappling with how to do teleneuropsychology and how we could consult our colleagues in other countries or trainees that, as you say, they might be, up and coming and actually have some great ideas, but struggle with the implementation. They need maybe more senior folks in the field for that authoritative voice to move that into actual clinical setting. What are your thoughts on that in terms of even, experts in a specific area being able to consult or have more of a network instead of just, patients within our state? How do you think that might play a role?
Well, I think the time is ripe for that. And fortunately, our field is full of really great people. Most of us are in the field with interests in education as well as clinical care, and most of us have some interests and certainly training and background in research as well. So the time is really ripe for our young folks to get the new ideas out there. I think there's going to be some new initiatives coming forth. Requests for applications for technology-oriented grant applications in this area, and so I think that's really ripe for that. I think to encourage people to reach out to some of the leaders in this area. Most are very approachable. Most neuropsychologists are really great people. They're very collaborative. They're used to teaching. They're used to collaborating, working as part of not only clinical care teams, but also as part of research teams as well. So identifying people who are, publishing in this area, or just have a known telepractice that's been going on for a while, contacting them, asking, how do I get involved? Or to even say, here are some of my initial ideas, bringing new ideas to the table as well. What about this type of a new test? What about this test in this environment? What's been done? Have you ever tried this out? There are a lot of people in this area that, for example, have done, like including my lab, we tried out other tests as well. We haven't published all the data we collected. We published on certain aspects of it. So there's a breadth of experience too for a lot of telemedicine provider groups that have been doing this a long time. For example, Dr. Hammer's group in Utah has evaluated over 400 patients using this sort of a remote distance assessment. So that's a wealth of information. And there are others across the country. The VA system has a huge and thriving telemental health network, and they've been doing this for a long time with a lot of measures as well. So finding those people that are in large academic medical centers, VA hospitals that are doing this sort of work, and then finding out, how do I get involved? The good news is that, how do you get involved? Well, if I'm in one city and you're in another, we now can communicate, and everybody's getting used to these televideo conference meetings now. So I think it's actually going to really pave the way nicely for increased research collaborations as well as clinical applications.
Mm-hmm. And I think to add to another field or area is that private practitioners can contribute to that science too. So one of the things that I think has been a theme that I've been hearing is the ramp up time to start telemedicine in academic centers, versus in private practice. We were able to do that about 4 years ago. So we've been able to see about 300 people. Now, I don't do full evaluations. They're usually brief, they're screenings, they're quick 45 minutes. I've already received the data in advance, and I meet with them. I do a brief questionnaire, and then I give them the results and a note the same day, and it goes right to their physicians. So part of that, I think there's people practicing like myself, where we're about an hour and a half from an academic medical center.
Mm-hmm.
And so what can happen is that people now have access quicker, and then actually go to the academic medical center, right? Our role, as we were talking about, our role is beyond testing. It might be someone looks like they're having a seizure. They sound like they have a concussion. We have a lot of medical knowledge and competencies far beyond the testing. And we almost, in some ways, can serve as a supplement to a primary care physician, or even in some ways be the referring provider, right? So in academics, we're typically referred from the specialist. In this type of scenario, we might actually be the first point of contact.
That's an excellent point. And I think there are many, many practitioners all across the country in all sorts of different settings that are doing much like you've described in your clinic for some time. What would be great at some point is if we can get everybody to start pooling data. And although, the practices differ, the platforms differ, the tests differ, there's a lot of variability, but I think we have to start somewhere. And I think that sort of pooling and shared experiences and sharing the experience like you've been doing, and through different webinars and podcasts, I think hopefully will pique people's interests in starting to at least put a toe into this environment, again, with the caveats we've mentioned.
Mm-hmm. Definitely. So we want to continue this conversation, and part of our goal is to launch a virtual summit, which we're going to have June 18th, 2020. And it's going to be an opportunity to do a radical collision. We'd like to think of it between neuropsychology, engineers, data scientists that understand big data, and neuroscience, and get clinicians involved and discuss digital transformation and brain health. So that's going to be the theme. We're going to be taking abstracts. We already have the Journal of Child Neuropsychology is going to open up a special issue. And I've been in contact with another journal. Our goal will be to have 25 publications by the end of the year, or within a year's time from the summit, so we can really propel the science. That's our goal. So thank you, Dr. Cullum. He's shared his time and expertise, and he's also agreed to be one of the speakers at our summit. So thank you very much. Lots of people are going to learn from our conversation today. We'll also be sharing resources based on his publications and the others mentioned in our conversation. Thank you.
Great, thank you.